The vast majority of assumptions that people make about their body and how fertility works are often wrong.
How early would you want women who want to eventually get pregnant to start thinking about fertility?
I think people should start thinking about fertility in their 20s.
Dr. Sekhon, a board-certified reproductive endocrinologist and fertility specialist at RMA of New York, works with patients navigating fertility every day. And in this episode, she breaks down how fertility actually works.
Human reproduction is extremely inefficient. The amount of effort you put in doesn't always equate to a better outcome. We're only expecting like a 20 to 25% max chance per month. A lot of times people just kind of chalk their periods up to, this is the burden of being a woman. They're being gaslit.
Hi guys, appreciate you tuning in for today's conversation. Your support helps us continue growing this show, so please do us a favor and hit that subscribe button, and let's get into our conversation today. Dr. Sekhon, I feel like fertility is one of those things that we don't think about until suddenly it's all we're thinking about. And in that moment, it can feel like there's a gap between what we thought we knew and what's actually true. And you guide people through this every day. So what are we most commonly getting wrong about fertility before we even start trying?
I don't mean to sound negative because I'm actually a very optimistic, positive person, but I'd say the vast majority of assumptions that people make about their body and how it works and how fertility works are often wrong. And it comes down to just people lacking fundamental knowledge. I think it's because it's viewed as not relevant, right, for a large part of your adult life when you're nowhere near being ready to start trying to get pregnant. It's like, well, why would I focus on that? I'll worry about that. That's a later problem, right? And we think we got some knowledge in school, but the focus was very different in health class. It was about avoiding pregnancy. And there wasn't a lot of focus on what is ovulation and how do you track it and what are the different red flags that can appear over the course of your life when it comes to your menstrual cycles and what could it mean? I mean, it was really about contraception and avoiding an unplanned pregnancy. That was really the focus. And there's no formalized education. And so people come to me at all different stages. Some people are like, I'm just here for a fertility checkup. I'm just here because I have no idea how I should feel about my body, my fertility, how I should be planning things out for the future. Should I be thinking about egg freezing? And then I have people who come to me and they're like, I've been trying for 2, 3, 4 years and I haven't seen anyone because I'm kind of nervous and I'm afraid about what you're going to tell me and everything in between, you know? And I think there's a lot of fear and anxiety and the unknown makes it worse. Oftentimes, I'd say majority of the time, I start every consultation with like a full biology 101 where I'm drawing the reproductive tract. It's like being in grade school and I'm teaching people what does ovulation actually mean? What's happening in the background? And just explaining it in a really easy, accessible way so that they feel, okay, this isn't as complicated. It doesn't have to be this scary, complicated thing. Even the biological clock, it's not as scary and complicated as what most people assume. It's not a cliff that you fall off of when you turn 35. Your fertility is a continuum. And I'm not saying that the biological clock isn't real. It is real. But I think if you know about it and you understand the accurate details about it, you can make real decisions and plan around it.
With the information that we have now, how early in an ideal world would you want women who want to eventually have babies and get pregnant to start thinking about fertility?
I think people should start thinking about fertility in their 20s, honestly. I mean, think about our parents' generation. Think about our grandparents' generation. When were they having children, right? And we always hear this narrative, and it's especially used to fearmonger on social media that there have been all these things in our environment that have shifted and, you know, fertility is an all-time low and we're seeing a lot more people who need assistance than in prior generations. But I think the fundamental shift is that people tended to try earlier. And therefore, they didn't really get confronted with the same issues that we are, right? And so I think that thinking about it doesn't have to be equal to actually trying to get pregnant, but just having an understanding will, even in a subconscious way, it's going to inform your decision making. I'll give you a personal example. When I was a medical student, I thought I knew what I needed to know to make basic decisions. And I kind of had this really cocky attitude towards family building. I was single and I said to myself and I said to my friends, I'm going to be one of those people that starts having kids in their 40s. And I'll just freeze my eggs or I'll freeze embryos with my eventual partner. It'll be fine. And everyone's like, oh, okay, that's cool. Like a lot of people weren't even familiar with what that was, but I knew I wanted to go into this field. And once I actually entered this field and started training as a fertility specialist beyond my OBGYN training where I was delivering babies and doing general GYN stuff, that's when I was like, you know what? Science is great, but I'm seeing a lot of people that were really sure about certain plans and timelines. And I'm understanding now from actually seeing these real life day-to-day examples of people struggling with different things that you can't always control everything. And science isn't going to be a perfect solve for every case. And that's when I went home to my husband, because at that point I had just gotten married. And I was like, I think that I should get off of the pill. And I think that we should change all our plans. And like, it's probably going to be harder. And I just think it's better to start sooner rather than later. We're already married. Like, what are we waiting for? And he was like, what? We had just bought a 1-bedroom. He's like, okay. And then I ended up having, luckily, no difficulty having my first, who's turning 9 this weekend. But then I realized in some of the testing I had done, just being a fertility doctor and wanting to be proactive, I had a lower egg count. And even though I know that that has nothing to do with my egg quality or my ability to ovulate a healthy egg, we only ovulate 1 egg per cycle, it still gave me pause because I thought to myself, well, what if I run into trouble and I need IVF and then my egg count's even lower later down the line. And I also felt really overwhelmed by being pregnant and then a new mom, going back to work after 7 weeks after a C-section. That's the life of an OBGYN. And I was like, I can't do this anytime soon. So I actually made the decision to be proactive and freeze embryos with my husband. But my point in telling you all of this is I know that my decisions were shaped by my awareness and the fact that I had the knowledge. And so I don't think that it's ever too early to get the fundamental knowledge. I wrote my book, The Lucky Egg, as kind of a fertility Bible. And my hope is this can be the thing that fills the knowledge gap and can be the health class 2.0 and that formalized education that we've all been missing.
Yeah. And I think for those of you listening that are in your 20s that maybe don't have a serious partner yet, but know that that is something that's coming in your future, I hope that coming out of this conversation, you can be a little bit more proactive about figuring out what's going on in your body and getting to know your unique situation.
Yeah. And there's so many different ways to build a family. Something I'm seeing a lot of nowadays is people coming in and saying, you know what? I thought I needed to wait for the perfect partner, perfect relationship or situation. And I've realized that it's a really important personal goal for me, a life dream to have a child. And I've realized that I'm enough. I don't need a partner to do that with. And that's a really strong personal choice. It's one that I respect immensely. It's one of the most rewarding things that I've done in my career is help women navigate that path. I've even helped men navigate that path. And so I think the world has changed. Expectations have changed in society. Not everyone has to want to have children. Not everyone has to have a partner to have children. And there's so many different ways that it can look. But the key is you have to have the right information so that you're making the right decision for you.
So say somebody comes to you in their late 20s, early 30s, and they say, I want to get pregnant in the next 3 years, 5 years. What can they start doing now? What can they start learning about their cycle, about their body that will help them in the long run?
Well, that's a great question. I think there's a lot of anxiety around being on birth control right now and a lot of misinformation about it. There's nothing wrong with being on birth control. So if you've been on long-term birth control pills and IUD, this is not something that's going to affect your fertility. Once you remove that block to your ovulation or you remove the IUD, which is essentially working by preventing sperm from getting to the egg, all of that effect is reversed and your fertility is restored. But I think a lot of people worry, okay, should I be off of the pill for years? Should I be tracking my natural ovulation? A lot of people don't realize when they're on the pill, that's not a real period. And that's okay. What you're doing is you're giving yourself small amounts of hormone, and then you're taking it away if you're taking that week of placebo pills that aren't actually medication. And then your lining breaks down with the withdrawal of those hormones. And so it's not coming from ovulation, like a regular period when you're not on the birth control pill. Where that's coming from is you have a bunch of eggs that kind of float to the surface of the ovaries each month in a process we cannot control. And your brain sends a signal to the ovary, and one of those eggs randomly gets selected to ovulate, and that's your one shot at getting pregnant. And if it doesn't happen, then that egg goes away, the hormone levels drop, and you get a period. So if you're someone who's not on the pill, it can be very useful to track your cycles. If you're on the pill, it's not bad to track your cycles, but it's less useful, right? Because you're just kind of tracking something that's an artificial phenomenon. But if you're tracking your cycles and you're not on the pill, there are things that you can learn, right? Just by understanding the frequency of when you get a period, that's going to tell you how often you ovulate, because that period's coming on because you ovulated an egg in the 2 weeks prior. And so if you're someone who's like, I never know when I'm going to get my period, that's something you should figure out now in your 20s and your 30s, because the most common cause of that are conditions like PCOS, polycystic ovary syndrome. 10% of the population has this, and it's an issue that can also relate to your metabolic health. So it's not just a fertility thing that you only need to worry about when you're ready to start, timing when to have sex because you want to get pregnant. It also is something that can increase your long-term cardiovascular risk, your long-term risk of things like diabetes. It can often be concurrent with symptoms like I keep gaining weight no matter how hard I'm training or eating well, and it's a real source of frustration. There can be skin and hair changes. So paying attention to your body and all the changes in your body, not just with your period, but throughout the cycle. How does it affect your mood? How does it affect, your day-to-day ability to function? Are you having painful periods? Are they heavy? All of these can be underlying symptoms of major gynecologic conditions, whether that be PCOS or endometriosis. That's a big cause of pelvic pain. And we're talking about it a lot more now, which I'm very happy about. But it takes an average of 8 to 10 years to get an accurate diagnosis. Every day I talk to women where I'm like, has anyone ever told you might have endometriosis? Because they're just mentioning it to me casually when I'm taking their medical history. They've had these debilitating periods, and that's why they started the birth control pill and then they went away. That's really relevant information. So not only should you pay attention to what your cycle's doing now, but especially if you are maybe inadvertently treating something by being on the birth control pill, which is not a bad thing. It's good. You're inadvertently treating something probably. You need to think back to why you went on it and what were your symptoms back then, because that can unlock really important clues to, things that could impact your future fertility.
And I feel like there's so many people like myself. I remember I went on birth control when I was in high school.
Yeah.
And luckily I had wanted to go off of it kind of post-college for no reason other than wanting to see if I could regulate my hormones on my own, because I knew that I had gone on it to kind of mask my acne symptoms.
Right.
And so then I went through this process of getting off of birth control and just seeing what would happen. But for people that maybe don't know what symptoms are being masked, what would you say to them?
I mean, I would say look out for painful, heavy, irregular periods. Also, if you feel like you have hormonal acne, or you start to feel like you're having hair growth in places that traditionally women shouldn't have as much hair growth, like on their face, on their chest, on their back, and also hair thinning where you wouldn't traditionally have it. They call it male pattern baldness. So having like thinning in the corners here, that can all be related to a condition called PCOS, right? And what that essentially is like your brain is trying to get your ovaries to listen, and they're not listening. And there's an overall theme of resistance to signals. So also resistance to insulin, which is how our body stores blood sugar effectively. You end up churning out more insulin, and that is the root of a lot of problems. It's pro-inflammatory. It can cause your ovaries to overproduce testosterone, and that's when you're getting a lot of the skin and hair manifestations. And it also can cause mental health issues too. A lot of people feel so vindicated when I tell them this. I'm like, the depression and anxiety and the sleep disturbance, because it can also be associated with sleep apnea. So it's so much more than fertility. I mean, people always say your period is your 5th vital sign when you think about pulse, blood pressure, temperature, your respiration rate. And I do think there is something to that. I think a lot of times people just kind of chalk their periods up to this is the burden of being a woman. This is just how it's always been. And they're normalizing it for themselves. And they're also sometimes having their symptoms and complaints, they're being gaslit. They're not always being listened to. And I think that the medical field needs to do better in terms of listening to women and really prioritizing not just, diagnosing them and treating their pain and their quality of life issues, but also putting real research heft and effort behind getting answers and finding better ways to treat women.
So when somebody comes to you and they're looking to start their fertility journey, what is step 1 for you?
So usually they're coming to me either if they aren't trying yet, but they want to think about fertility preservation for the future, or if they've been trying on their own and it's not happening. And so usually the guidance is track your cycle, figure out when you're ovulating. If you have a regular interval between your periods, it's going to be easier to kind of predict when your ovulation is coming. And you don't have to do all the guesswork. You could plug it into an app, right? And it's going to kind of model out, okay, this is when you're typically ovulating in the next cycle, so that you can actually know, all right, I have this runway of time to put in effort, and let's try to have sex in that 5 to 6 day window leading up to ovulation. And that's going to give me the best chance of sperm and egg meeting. And knowing that it's very much like playing slots, right? Like pulling the lever of the slot machine is akin to timing when you're ovulating and having sex right before that time. The rest of all of that is left up to chance. We don't know if every egg that you ovulate is, we know not every egg that you ovulate is going to fertilize successfully. We don't know if that fertilized egg is capable of turning into an embryo and traveling to the uterus. And if it's a healthy embryo, there's a lot of what ifs. And it's like everything has to line up. And this is one of the fundamental things that people don't realize. And they often get very dejected very early in the process of trying to get pregnant. Human reproduction is extremely inefficient, at best in your 20s. And if you're in your 20s and you're hearing this, know that you are presumed to be in the it's as good as it gets phase of your fertility and your egg quality. But even still, when you pull that lever of the slot machine, we're only expecting like a 20 to 25% max chance per month. This is why it is normal. It is the one time we'll all say, you know, that saying the definition of insanity is doing the same thing over and over and expecting a different result. That's actually not applicable here. That's my whole life as a fertility doctor, is encouraging people and saying, listen, it's only been 3 months. You can't expect, you know, a 20% chance per month to finally, you know, to hit the jackpot after 3 times. So it might make sense if you're under 35, especially if you're in your 20s. I think you have time to be persistent. And I think if it's been longer than a year, that's when it's the official guideline that you need to see an expert like me. And if you're 35 and older, don't wait longer than 6 months. And if you're in your 40s, I don't think that this is overly proactive. You should see someone at the 3-month mark, right? The reason that guidance exists, those guidelines exist, is because we know that our ability to randomly ovulate, because it is very random, like a lottery, you ovulate 1 egg. The chance of that egg being genetically normal and healthy and having what it takes to turn into a baby starts to dramatically shift in a negative direction over the age of 35, but it's never perfect for anyone. So like in our 20s, even then, some eggs that we ovulate just don't have what it takes, but that becomes a more prevalent issue, and it becomes kind of the exception to the rule to ovulate a healthy egg as we enter our 40s. Having said that, we still do have normal eggs in our 40s. And so it's kind of like when people say, what do people need to know about their fertility? I would say it's never the extreme thing that, you know, you should get pregnant in the first couple of tries, or, you know, if you're in your 40s, you don't have any good eggs left. It's the truth is somewhere in between. People get pregnant and ovulate a healthy egg in their late 30s, their 40s. But it's important to have a plan and give yourself a shorter runway of time so you can be really proactive.
And I feel like sometimes, like I know for myself, when I first went to my doctor and I said, oh, okay, we're going to start trying to get pregnant. And she kind of gave me that year marker too, as, you know, you're going to try for the year, see what happens.
Yeah.
I remember thinking, oh my God, a year?
I know. Yeah. I mean, it's never wrong to see someone sooner. And I always say you don't have to follow any rule book. And if you have irregular cycles, I mean, you should skip all those steps, because if you don't know when you're ovulating, you're not really in the game. What I mean when I say that is when you ovulate, that egg lasts for 12 to 24 hours. And if it's not fertilized in that time frame, it basically goes away, and then you have to wait till the next attempt. So if you never know when that's about to happen, even if you're someone who has sex every day, which I don't know who those people are, but even if that was true, this is still extremely less efficient, because you're not getting as many shots on goal as the person with the clockwork every 28 to 30 day cycle. So if that's you, you should go straight to a fertility doctor, because we need to figure out why your cycles are irregular, correct those underlying disturbances however we can, whether that be through recommended lifestyle changes or with the help of medications, right? And come up with a strategy or an approach, because otherwise you're going to end up wasting a lot of time, and you're going to be very frustrated. And at-home trackers like peeing on the ovulation predictor kits, you're going to get a lot of false positives, because you're picking up this false signal where your brain's just yelling at your ovary, telling it to, hey, I want you to ovulate, I want you to listen. And you're going to often pick that signal up and think you're ovulating when you're not. So I think get plugged in with experts early if anything is off about your cycle, whether it's irregular, whether it's painful, and not only if you have a diagnosis of a problem like endometriosis, because a lot of people go undiagnosed.
Yeah.
Oftentimes, I, as the fertility expert, the specialist, am the first person to tell someone that they have something going on with their uterus or their ovaries, something that could be the underlying cause of their infertility. We're not doing a standard ultrasound on all women as they enter their 20s. That's just not a standard of care thing. And maybe my perception is skewed from all the things that I see, but I'm kind of like, what's the harm? Why aren't we doing that? And there's such a variation. Like some women are like, yeah, I get one of these every year when I go for my annual, or I've had one or two, in the past 5 to 6 years, whenever I had a complaint, my doctor would do it. And then there are some women that come to me in their 40s and they're like, oh, I've never had this test. What is this? And I'm like, no one's ever looked at your uterus or your ovaries? That's kind of crazy to me.
I was somebody that had, all these weird symptoms. Like I've always had acne. I had irregular hair on my chest. Like I had all of these signs of what is PCOS,
Yes.
but I had never gotten tested for it. And I remember I had been on Accutane twice, and my dermatologist had said, like, after the Accutane kind of failed a few times,
Yeah.
she was like, have you ever gotten tested for PCOS? And of course, like, I just kind of said no and almost like shrugged it off and was like, I don't know what that means. I'll deal with it at some point. But it wasn't until starting my fertility journey that I realized, I actually have PCOS, and this probably is something that I'm going to have to figure out in order to have a healthy pregnancy.
I think the important thing to know about PCOS is that anytime in medicine you have something that requires nuance, where there's a spectrum of ways that it could present, it's always going to be more likely to fly under the radar, right? And it's more insidious. And it's because I think it's human nature to be like, okay, this is what I learned in medical school. This is what the textbook picture of PCOS looks like. It's someone who struggles with their weight. And a lot of women with lean PCOS are misdiagnosed as a result. And as a fertility doctor, I'm much more familiar with PCOS than the average clinician. And so I think it is a major source of frustration. A lot of women come to me to talk about egg freezing, and then they leave and they have a new diagnosis of PCOS or fibroids or endometriosis. But it's really important. And I always say, if I see something, I'm going to say something. I'm not going to just focus on the reason that you came to see me, because this is fundamental information about your body that you should have already had.
Are there any wearables that you recommend people to kind of start wearing or using when they're trying to get pregnant?
Wearables are tricky because most of them are detecting temperature changes, right? So when your temperature rises by like half a degree, what that's telling you is now you have gone from estrogen dominance in the first half of the cycle. Your ovaries are pumping out estrogen in increasing amounts, starting from when you get your period. And then you start recruiting a new follicle, which is a bubble of fluid that contains a maturing egg. And then that's the one that bursts and releases the egg that you ovulate. That's when you have like peak estrogen. And only after ovulation is progesterone starting to rise. And that progesterone actually causes your blood vessels to dilate or relax. Your body temperature changes just in a subtle way. And so when you have a wearable or you're doing the basal body temperature tracking, that's another form of cycle tracking, you're detecting that rise in estrogen, and that's telling you, it's like a confirmatory sanity check of sorts, where you're like, okay, this means that now my body is being affected by progesterone. But remember what I said, you really need to concentrate your attempt of when to have sex and when to try in a given ovulatory cycle. In the 2 to 3 day window, that's like the tighter window, but even in the 5 to 6 day window leading up to ovulation, because sperm gets into the reproductive tract and will sit around and linger for like 3 to 5 days. The egg will not wait around for the sperm. So in order to get maximum chance for a meeting to take place, it's really about doing it before. So if you are detecting your temperature rise, that's not super helpful to be like, okay, in this cycle now it's going to inform when I should try. It's already too late. So I think if you have a really regular cycle and you're always noting your temperature goes up during a certain part of the cycle, then you can kind of use that information to understand when you generally are ovulating. But I find it less helpful. I think that, wearables can make you more aware of your habits. And I think we're so busy and we're in such a state of just like rushing to the next thing that it's very easy to forget about some of the basic things that we know have a major impact on our health, like getting enough sleep. So like for me, wearing an Oura ring was helpful to kind of be more mindful about my sleep patterns. And I could kind of also start to see a pattern between like when I was looking at my screen right before bedtime, or I drank, caffeine later in the day, and then I had a more fitful sleep. So that's how I think of trackers in terms of fertility tracking. If it is plugged into like those apps that you're also plugging in the first day of your menstrual cycle, maybe like in a layered effect, it can give you more accurate information that's a little bit more granular. But I think it depends if you're a data person. I have some patients that come to me and they're like, honestly, I'm getting driven crazy by the data overload. And they feel so relieved when I tell them, listen, I can just do monthly, blood work and ultrasounds because your case is a bit more complicated. You have PCOS and these home trackers are probably not great for you because you're getting a lot of false signals. And they're like, thank God, because this is too much for me, So I think if it's overwhelming you, then you don't need to incorporate it into your regimen when it comes to cycle tracking.
Yeah, I like that. I think of that too with fitness sometimes. It's like either you're a data-driven person when it comes to like cutting macros, micros, or you're somebody that just wants to be told like how many minutes a day do I have to work out?
Exactly.
What should I be doing?
I'm in the latter camp.
I always feel like people that are more sciencey too are like they would be the more data. Are you not more data-driven with like how you work out?
I am, but I feel like I'm so cynical about I feel like we all are overloaded all the time with information. And so I'm kind of like a less is more type person.
Yeah.
I'm like, just show me what's relevant, and I think all of the excess noise, I find it frustrating.
Mm-hmm. Also, it's figuring out what works for you and you know your body.
Yeah. I think with the Oura ring for me, like the sleep was the most illuminating part of it, but I don't know. I think that there's good and bad to it. I think a lot of times people get really fixated, and there's a huge mental health component to the trying to conceive journey. And I think sometimes we can get mentally very fatigued, and we should probably overestimate that from the get-go to avoid even hitting that wall, because that's what leads to a lot of people dropping out of trying, whether they're trying on their own, and then they're like, okay, I just need a break, right? And I think breaks are good for you, but sometimes people go away for like a year or two when they had complicated issues and they actually needed treatment for really legitimate problems that we knew were at the root of their infertility. And the reason for, those long pauses are mental burnout. And, people sometimes drop out of treatment and don't return. And as a fertility expert, this is a couple or this is an individual that could very likely be successful. We just need to be more persistent. And so I think protecting your mental health is important. So I talk about that a lot in my book and with my patients. I think about the patient that has 30 different supplements like littered all over their bathroom counter. I mean, that's exhausting. Can you imagine taking that many supplements per day?
I can, because I did do it for PCOS. Wow. And I do think it worked.
Yeah. I mean, there can be something to certain supplements for sure. But I think a lot of times people grind their gears, and it's like, I think keeping things simple and really trying to focus on the big picture is so helpful to your mental health. And I think if you're someone where the data makes you feel more relaxed because you're like, I just need more to feel like I'm as informed as possible, then great. I think whatever works for you, but you don't have to do all the things. I think when you enter the world of trying to conceive, especially if it's been a while, if things are starting to get more complex, if you're going on Reddit, you're starting to enter the forums, it can feel like everyone's speaking a different foreign language. And there are all these people that, are using jargon, and you feel like you're like an alien, and I think that a lot of patients feel that way. They're like, oh my gosh, I feel like I should be doing like 50 different things and I'm not doing anything. But this is one of those areas where the amount of effort you put in doesn't always equate to a better outcome. And that doesn't mean we throw up our hands and don't try, but I think we really have to be mindful about where we put our efforts, because there's only so many hours in the day and only so many things we can be focusing on. And it's like a marathon, right? If we're talking about running today, it's like, this is not a sprint. This is for so many people a marathon, and you need to be able to stay in it to get to the finish line.
Yeah, and I think it's so important to remind people that, because I have so many friends that are on different varying fertility journeys, from people that get pregnant in the first month to people that have endometriosis and it is taking a little bit longer. But everybody's journey is different. So I'm curious, from that perspective, what advice do you give to patients to manage kind of the mental stress of it? Because I feel like so much of even being pregnant and trying to get pregnant for a woman is having to compartmentalize it.
Oh, 100%. Yeah. I mean, and especially if your journey is more complicated and it involves fertility treatments, compartmentalization is your friend, because I think it's like looking at a whole mountain and being like, oh my God, there's the peak of Everest. It's like, that's so daunting. I think to say like, this is where I need to summit. I need to get through the retrieval, and then I'm going to have a little rest stop, and then I'm going to wait for these results. And then the next step is preparing for the transfer, or maybe do we need to do another egg retrieval, right? So I think just kind of having like your small baby steps type goals. Also, I love what you said about everyone's on their own journey. I think comparison is the thief of joy. That is a very true statement when it comes to fertility journeys. And I think there's something great about people sharing their story. I think it helps others feel seen and less alone. And it's a wonderful community. It's like the worst club with the best members because everyone shows up for each other, strangers on the internet who will never meet in real life. People really care about everyone's success and journey. But I think there is a double-edged sword to that because it's always like, well, why did it work for them? And I did all these things. I did these surgeries. I did these procedures, and I'm still kind of stuck in the same place. So it's a little tricky, and it requires so much mental fortitude. And I always say over prepare. I have a whole mental health toolkit in my book. I talk about mental health through every chapter because I believe the mental health struggle and journey associated with issues like a pregnancy loss is very different from someone who's like, I'm single, I've been told I just have endometriosis and I have a lower egg count. And, there's different stressors in all of that. And I think those mental health aspects have to be addressed in a very unique way.
Mm-hmm. Yeah. And I feel like women, we need to just be comforted in those situations too. And just feel like we're not alone because I feel like pregnancy can feel so alone and there's so much blame involved. Like it's like somebody has a miscarriage and then I feel like
what did I do?
Right.
What did I not do? I mean, I hear my mom talk about all the time. She had my brother at 25 weeks.
Oh, wow.
And it was, he's my younger brother. It was her last child. So she was older. She was almost 40. I'm sure her age was a risk factor, right? But she's always like, I was working too much. Like she still talks about it. Mm-hmm. I think there's so much trauma and self-blame and shame. Like there's so much to unwrap. And we just, as women, need to be easier on ourselves. I mean, so much of the locus of responsibility and control is placed on us because we're often the one carrying the pregnancy. Also, we have this pesky biological clock where everyone knows we're not making new eggs and that there's this age-related decline in egg quantity and quality. Men don't fall under that same scrutiny because there is this feeling that they're invincible, right? They're always making new sperm. Every 74 days, new sperm cells are generated. This is why we know older men can father children. But is it benign? No, there are risks associated with it. And 50% of couples who have infertility, there's a male factor. Mm-hmm. And so I think that so much of the focus tends to be on what can a woman do? Everyone's talking about trimester 0 on social media right now, which is this concept of you need to concentrate for about 3 months, the length of a trimester, before getting pregnant on being perfect. And it's just not realistic. I think it's a good goal to be the healthiest version of yourself, to control chronic medical conditions, to switch from any pregnancy unsafe medications to alternatives that are treating any underlying chronic medical conditions that we know are safer in pregnancy and get stable on that before getting pregnant, right? Mm-hmm. It's always better to kind of prepare ahead of time. Getting healthy in terms of our behaviors and the things we're avoiding, eating well, exercising more, pretty much anything better that's better for your heart health is better for fertility. I'm not discounting all of that. I think that's really critical. But I think feeling like you have to live in a bubble, that you can't use deodorant, that you have to switch every cleaning product in your house, I think that a lot of that is based on magical thinking. A lot of it's based on junk science or, salacious clickbait headlines. And it's making people afraid to live their lives. And it's robbing them of joy. And I think it's the wrong thing to focus on. I think it's tricky because I'm not saying warm up your food in plastic. It doesn't matter. I think that we do need to be mindful of our environment, but we cannot control everything. And I think that you do have to relinquish some control and realize which levers to pull that are actually going to make a difference, that are worth concentrating your effort on, if that makes sense.
Let's talk about trimester 0 because you're so right. It is taking on a life of its own on social media. I've heard it referred to as trimester 0 and then also training for pregnancy.
Yeah.
So what should a man and a woman both be doing in trimester 0?
I actually like the concept of training for pregnancy because it's exactly what it is, right? Like when I think about a patient who sits in front of me, and a lot of people come to me and we have these preconception counseling moments where I'm going through their medical history and trying to understand, is there any chronic health issue that A, hasn't been diagnosed and isn't under control, or that could be optimized better? Oftentimes I'm talking to their specialists. I think that it's a really good thing before you start trying to get pregnant to ask yourself, are you up to date on all your cancer screening, right? Because pregnancy, hopefully, is a 9-month-long process. And during that time, there can be limited options in terms of certain tests that can be done. For instance, you're not going to do a biopsy of the inner part of the cervix, right? So if someone has an abnormal pap smear, before I'm doing any sort of fertility treatment to get them pregnant, I'm like, hey, if you're due for a pap shortly, like let's just get that done now to make sure if there's any intervention that we otherwise wouldn't be able to do or it wouldn't be recommended or safe in pregnancy. I'd rather get that out of the way now so that we know you're safe, right? So really prioritizing the person who's going to be carrying their health above all, and making sure that they're good, and that all issues are kind of tucked. And then like, what is the lifestyle, and I think people don't talk enough about sleep, the role of sleep. Sleep plays a huge role in our hormone health. And I think it's really important to be consistent with sleep. A lot of people have sleep disorders that have yet to be, dealt with. I think, what we eat matters. And so really trying to clean up our diet and eat more of a variety of, vegetables and fruits. This all sounds very common sense, but I think it's important to cut down on processed foods and foods that are inflammatory and focus on a Mediterranean style diet. A diet that would be better for heart health is always going to be better for fertility. Not drinking, because this is something you're not supposed to be doing during pregnancy and for a good reason. And so kind of cutting down on that and really minimizing alcohol intake. While you're trying to get pregnant, can you have a glass of wine here or there? Sure, fine. But we usually say less than 4 drinks in a given week. And it is kind of like training for pregnancy, because once you're pregnant, you shouldn't be drinking at all. There isn't an established safe level of alcohol that we know for a fact isn't going to affect fetal development. Not smoking, right? Smoking's terrible for our fertility. It causes us to deplete our eggs faster. You can go into menopause earlier. It can affect your egg quality. And it's obviously very dangerous in pregnancy. And so if you're someone who is addicted to nicotine or you're vaping, like these are things that you should really be training for pregnancy and cutting down and really eliminating eventually by the time you're pregnant. Weight management. This is a huge hot button topic, but we know that every outcome in pregnancy that we want to avoid, the risks are elevated by 2 factors: excessive weight and advanced age. And there's one of those things that we can actually try and control. And this is not coming from a place of shaming anyone, but it's to say, do your best, and I've had some patients who've really struggled with their weight, and it's not a moral failing. It's just how their body is genetically wired or metabolically wired. Sometimes they have insulin resistance. A lot of times they do. And sometimes it makes sense to even get the help of experts to maybe, rest on the help of certain types of medications. Like GLP-1 agonists are a big topic right now. You can't be on them when you're pregnant because we don't have the safety data to say that that's okay. And there are some studies that have shown lower birth weight in babies that were born when their moms were on meds like Ozempic, and even some abnormalities or birth defects. So we're not there yet where we can say it's totally safe. We say you should have a washout period where you should be off of it for at least 2 months. So sometimes optimization in that trimester 0 might look like taking a pause and doing something first and optimizing your health in some way, and then saying, okay, now I'm in a better place to start trying. But it's tricky because you also have to contend with the biological clock. And so, studies have tried to look at this, like in women who are approaching or are in their 40s, but also are struggling with a high BMI or being overweight. Does it make sense to take 3 to 6 months and wait to reduce their weight if they can? Or is the biological clock more of something that we should be, focused on? And so, there isn't a clear answer. And I think you really have to be mindful of all of the things. Sometimes I see a lot of people telling patients to kick the can down the road because they're like, you have to be a perfectionist and you should be on a supplement regimen for 3 months because that's the amount of time it takes to improve egg quality. You hear a lot of that. It's not actually rooted in science. And sometimes I think it's bad advice, particularly for older women or women who have a very low egg count.
Mm-hmm. Yeah, I feel like there's a lot of misinformation out there too. And then there's a lot of personal experiences that might not be rooted in facts that are out there on the internet.
Totally. I think that's probably one of the most difficult challenges. I talked about how great the community is, but I think people sharing their personal stories, it can also lead to these like anecdotes. And oftentimes it's like, okay, someone who might have had a long journey where they did multiple egg retrievals, and then they're like, and then I added in this supplement, and then I had a much better retrieval outcome. Well, your doctor was probably tweaking things along the way as well, right? And so I think it's not always scientific, the information that we're getting or that's being shared online. Mm-hmm. And, it's not always a harmful thing, but I think that it can be harmful because it can waste people's time, it can waste money, it can waste their most valuable resource, which really is time, and it can burn them out. I think that's the biggest thing.
How can, if we're talking now too about like physical training,
Yeah.
how can overtraining physically affect your fertility?
So it can, it has to be often extreme. And sometimes it's the combination of overtraining and not taking in enough calories. And so what happens, it makes sense when you think about the fact that your brain is like the central command tower, right? It's controlling a lot of the major hormones in our body. And so, your pituitary gland, which sits right here in the front of your brain, is basically sending signals to the ovary, and then one of those signals is going to hit a follicle and get you to ovulate. If your brain is detecting that there is a caloric deficit or an energy deficit, it's going to shut those signals down and say, we don't have enough energy to keep functioning just ourselves. Like we have no business trying to support another human being growing inside of you, right? And so that's kind of like an evolutionary protective mechanism where you stop ovulating. And so I see this a lot in people who've had disordered eating. And sometimes you see it in athletes. Like I'm talking people training for the Olympics, people that are, training and doing high intensity things for like 8 to 10 hours a day. I don't see it in a lot of people that are like training for a marathon because I feel like it's like a temporary thing. And most people aren't doing things in an extreme way. So I think all too often people hear this and become very afraid of moving their body and they think that it's dangerous. I've heard a lot of people say like, I'm trying to get pregnant now, so I was told by this person, sometimes it's an expert, oftentimes it's not, that I should, be avoiding high impact workouts. I shouldn't raise my heart rate above a certain level. I should really aim to keep my body temperature. And I'm like, your body is smart. It knows how to self-regulate. And so I think there's a lot of bad advice. And I think that movement is such an amazing form of medicine for our mental health. And so telling people when they're already in an anxious state because they're trying to conceive, they're trying month after month, or they're pregnant, and there's so many things to be anxious about when you're pregnant. I'm sure you can relate to that. Taking away a major tool that they have in their toolkit to manage that anxiety is not helping them. And there's so much data now that your pregnancy is always going to be healthier if you're incorporating movement. It gets harder, as you know, when you get into the later stages of pregnancy. I remember I loved Pilates, and, even by the time I was like 20 weeks, it kind of felt weird to do some core exercises. So you make modifications, but it's really important to keep moving. It leads to better obstetrical outcomes. It leads to better delivery outcomes. I mean, it's always a plus. And I think nothing you're doing should be extreme. And, if you're training and you're training for a marathon, you need to be appropriately eating and taking in the right amount of calories to support all of that.
Right. So it's really meet your exercise with proper fuel.
Yes.
And you'll be okay.
Exactly.
I also felt too, like when I got pregnant, what I was really happy that I was doing prior to becoming pregnant was keeping up a consistent workout regimen.
Yes.
Because
it makes it easier.
It makes it easier. And my doctor did say, obviously now he's a little bit more resistant on all the running.
Yeah.
But he did say, whatever you were doing pre-pregnancy, you can continue to do.
I always say that.
Yeah.
Yeah. And I have told patients to pause for short periods of time, particularly during certain treatments, whether you're freezing eggs or you're trying to get pregnant. If you're going through an egg retrieval process, it involves your ovaries getting enlarged. So there are exercise restrictions. They're very temporary. Usually it's like a few days into your shots. And some doctors, just to be on the safe side, will say the day you start your shots, like stop doing any high impact workouts or anything that's core intense, like anything that could bounce or twist your ovaries around. I would say don't jostle your ovaries. That's how I always describe it to my patients. And that restriction goes into effect, at an early stage once we start stimulating the ovaries. And after the egg retrieval, it's not like magically the ovaries shrink right away. It takes a week or two for them to kind of go down to their normal size. And that's when the concern is no longer there and the restrictions are lifted. And usually a good rule of thumb is like wait till you get your period 1 to 2 weeks after an egg retrieval. When you're ovulating and you're just trying on your own, or even if you're doing more laid back treatment options, like there's something called medicated IUI where people are taking medications to boost their ovulation, your ovaries aren't getting big. And so I really don't think that you need to be restricting, what exercises you're doing. Obviously talk to your doctor, but I think if you get the sense that there's this overarching recommendation to cut out exercise and it seems overly restrictive, don't be afraid to advocate for yourself and ask the why. Because sometimes I think in medicine, we don't trust patients enough. And maybe it's like we're erring on the side of safety. We're like, well, if we give nuanced information, people are going to get it wrong. And then someone might try to run when their ovaries enlarged. And we worry about the ovary twisting, right? It's a very rare but painful complication. And I think people are like, let's just err on the side of caution. But again, I don't know, as a woman who's gone through the journey of trying to conceive, getting pregnant on my own, trying to conceive with the help of IVF, having gone through all the different types of cycles, movement was a very important thing for me to deal with the anxiety and the ups and downs that came with those hormonal changes. And so as a doctor, I've made a huge commitment to really being more nuanced in my guidance. I put together a program with Megan Roop from Sculpt Society.
Love Megan Roop.
I love her too. She's so wonderful. And she had this great, prenatal series because she's had 2 babies and she shared her journey and her fitness journey throughout all of that and also postpartum. But she and I paired up because she was like, I want to be able to come up with a doctor-approved program for how people can move their body, whether they're going through an egg retrieval, if they're recovering from a miscarriage. Not saying that you can't take a break and you have to keep working out, but for some people it helps them, right? And they're worried about like, how does your body change and all of these different things that can happen as you're trying to get pregnant. And so we came up with, all these like fertility safe workouts. And it was funny because for some of them, she's like, wait, you mean I can only do arms and walking? Like, what do you mean? And like, there were some, restrictions even with her program, but I think there's a way that we can give women the tools so that they can make better decisions for themselves and take care of their mental health. I don't think we need to be overly restrictive.
That's great that you guys did that.
Yeah.
Because that is so helpful for somebody that, is listening to this and they're like, okay, I still want to err on the side of caution.
Yeah.
Go straight to Sculpt Society and check that out.
Yeah, I think it's fantastic.
Also, I love Megan because she, on her app, does a lot of pregnancy safe workouts.
Yeah.
Which is another really overwhelming space.
Yes.
I'm like, what core can I do? What can I not do? And it's really helpful.
Yeah.
And I also do have to say, I think your body tells you what you can and can't do. Like I was somebody early on that had to cut out core when I got pregnant.
Yeah.
Because it just didn't feel right.
Yeah.
And that's it.
I get that. And there's some people that are like front and center at the Pilates and yoga studio. And I'm like, how are you doing that at 30 weeks?
Apparently there's people that do Tracy Anderson, the heated workout, all the way through their
God.
pregnancy.
That's crazy.
Yeah.
I would vomit.
Same. Well, how do you feel about heated workouts when pregnant?
I think, define heated because there's some that are like super intense. And I think the problem with an overly heated room, like I'm like close to 100 degrees, is that you don't have the ability to regulate your body temperature. Like, I think it's crazy when people are like, you're working out in a normal temperature room or outside, but don't let your body temperature get above a certain level. It's like, that's what sweating is for. That's your body's natural mechanism to shed heat. But if you're in a really hot room, like that's not going to help very much. It's like being in a hot tub, right? So there's certain extreme temperature environments that we advise pregnant women to stay out of. In terms of your fertility, I don't think it's going to impact anything, but just as a precaution, if I've just done an embryo transfer on someone, I'm going to say to them, let's avoid saunas and hot tubs or anything extreme. I think our body knows how to do its job and regulate itself more than people give it credit for. But, I think once you're at a certain point in pregnancy, you do have to think about how that extreme heat could affect fetal development and things like that. This is why we are very proactive about treating fevers, especially in the first trimester, because we know not controlling the maternal temperature can actually lead to a higher incidence of problems in the development of a fetus. So I don't think people should feel worried if it's like hot outside, but I think being in an environment where everything is hot, your body's going to have a harder time regulating.
Right. And then on top of that, you're doing an intense workout.
And you're prone to low blood pressure just because of the natural changes in blood volume in pregnancy and how your blood vessels behave. And so you just don't want to predispose yourself to, fainting and things like that. And even if you're going through a fertility journey, some of the medications that you're on, those hormone changes can have a profound effect on your blood pressure and your ability to kind of recover from workouts and things like that.
So I like that we referenced a few treatment options so far. We've talked about IUI, we've talked about IVF.
Yes.
Let's dive a little bit deeper into those because for me, for example, like I am not as familiar with IVF or IUI just because I haven't been through the process yet.
Yes.
I, of course, have seen people document it on social media, and I love when I see people documenting their egg retrievals.
Yeah.
I love when I see somebody documenting their IVF journey.
Right.
Because I think it's really important, and it's cool to get a little inside look.
And it's so personal.
And
it's
so
like such a privilege that they're letting all of us in on their journey.
It is such a privilege. And also so many of us are going to have to go through one of the treatment options at some point. So let's talk about the different treatment options available. What do you typically recommend patients start with? And then what can they progress to?
I love this question because this is like the fun part about my job. I'm a very strategic person and I love planning. And so I do love helping quiet the noise and redirecting focus. And so when someone comes to me, if they're a couple and they've been trying to get pregnant for a certain period of time, first step is testing. And we're testing for core things. One is the sperm, because 50% of couples will have some sort of sperm quality issue. So we look at it under the microscope and we're like, is there enough sperm? Can it swim in a forward direction? Is there enough normally shaped sperm? And we're looking at all of those parameters in totality. And if it's above a certain threshold where we're like, okay, there's at least 10 million total motile sperm, it's called the total motile count, then we're like, okay, then you have either option. Like we can rely on sperm being able to travel and get to where they need to go. If it's lower than that, that's when we might need to kind of take the reins and say, there's probably not enough to get to the egg. And even like inseminations where we're dropping sperm off at the top of the uterus, that isn't enough of a shortcut. We might need to take the eggs out of the body, IVF, and put them with sperm directly, maybe even inject one sperm into each egg. That's a very successful way to overcome a lot of forms of male infertility that can't be overcome by just lifestyle changes or certain medications on the male partner. And so we're testing the sperm. We're testing to see, are the fallopian tubes blocked? This is where the sperm and the egg are supposed to meet, right? If you think about the diagram we've all seen about our female reproductive tract, it's like you have a uterus, you have fallopian tubes, and then they connect the uterus to the ovaries. So there's a test. You can go and get a test where they put dye in the uterus and basically watch it spill out of either tube to prove that it's open and there's no blockages. There's a lot of reasons why women might have blockages, like endometriosis is a risk factor for that, having prior infections you didn't know about, or surgeries and things like that. So we want to make sure they're not blocked. If they're blocked, then we should do IVF, because taking this process outside the body allows us to bypass that blockage. We create the embryos outside the body. We put an embryo inside the uterus and it doesn't matter. We've addressed it and worked around it. I care about the uterus. Are there any things that are getting in the way, taking up valuable real estate from where an embryo would want to implant? That's more, if we find something like that, is there a role for surgery to correct it, right? And then the last component, which is the more complicated one, is the ovaries and the eggs they contain. Can you ovulate regularly? Are you someone that has problems with ovulating because of underlying PCOS? Like, we need to figure that out. Or is it more that your brain stops sending the signals out because of a prior eating disorder, or you were training really hard? Like, these are the things that I'm thinking about. Now, let's say all those tests, including hormone tests, which we won't get into all the nuances and details, but let's say we do all the battery of tests. In my book, actually, the diagnostic chapter, I have like tables and tables that are like, if this is your situation, these are the basic tests. Because I think a lot of times we just need to simplify things for people, right? But let's say you do all the tests and they're normal. That doesn't mean I'm going to say, okay, good luck, keep trying. We have to do something to make this really inefficient process more efficient. And that can be two different buckets of treatment. The first one is called medicated IUI. And I always say, think of it like speed dating for your reproductive tract, right? You're not doing anything that different from what the couple has already been doing on their own, which is ovulating one egg, hoping for the sperm and the egg to meet and for something to happen. But you're giving both things a boost. You're saying, okay, to the female partner, take this pill for 5 days, meds like Clomid or Letrozole. This is going to fool your brain into thinking there's not enough estrogen, and it's going to send a stronger signal, and it could give you the opportunity to release 2 or 3 eggs. And then at the same time, let's place the sperm at the top of the uterus, wash it, concentrate it, and really put the best swimmers right at the top of the uterus so there's more eggs and more sperm meeting. And that's going to increase the chance that there will be a successful meeting that takes place. It's not that different from what you're doing on your own, so it might improve your overall chances by like 5%. So if at 35 every month when you ovulate, there's like a 15% chance that all those things will line up when you pull the slot machine lever. If you're doing a medicated IUI each cycle, it's improving your chances by maybe a few percentage points, like 5% or so. So it might take you from 10 to 15% or 15 to 20%. It's not going to be an overnight success. I don't ever expect the first one to work. This is like the long game. I usually say, okay, we're going to do this. Great. Maybe we try it for 3 or 4 months and then we regroup and see how you're feeling. Because oftentimes people are like, oh, this has to be easier than IVF. I'm just taking a pill, coming in for an ultrasound. you're putting sperm at the top of my uterus in a procedure that feels like a pap smear. It seems pretty low key. But I think doing the same thing over and over and feeling like I'm doing an intervention, why am I not getting pregnant? And hearing your doctor say, well, we don't expect it to work. Like, this is going to take time, and then it might still not work. That can be very difficult. So I usually say, like, let's check in after 3 or 4 months. You know, you're coming in periodically throughout these cycles. You're also trying on your own on top of it, because the more sperm, the better, right? So this doesn't mean there isn't a way for you to get pregnant from having sex. Like, you're incorporating that. That option can take time to get there. It may not work. And at a certain point, you have to know when to pivot. It does introduce the risk of twins, because you're releasing more than one egg. Oftentimes people think IVF is more aggressive, so there's more twins and triplets. It's actually the opposite. IVF has gotten so much more successful that now it's not justifiable to put in more than one embryo, so there's a much lower risk of twins.
I like that you say the risk of twins.
It
because
is.
I am like at 8 months pregnant now. I'm 8 months pregnant. I wish I was pregnant with twins.
Oh, really? Oh my gosh.
Two done in one pregnancy.
But imagine how you're feeling now and how that would be compounded by carrying 2 babies, right?
That's true.
It's really tough, but it's not even just your quality of life and how you're feeling. There's a 6 times higher rate of preterm labor. And as someone who had a preemie brother who spent the first 5 years of his life in the hospital, I know all too well all of the other complications that can cause. And also anything that happens in pregnancy that you want to avoid, like diabetes, preeclampsia, preterm labor, all of that is heightened by twins. So I don't want to scare anyone who's listening who might be carrying twins. I mean, it can be very safe and it can be something that is a beautiful thing, but you usually want to see a high-risk specialist who's managing you and monitoring you closely for complications. So if we can avoid it, we do. And that's why as a fertility doctor, I say it's a risk, even though twins are super cute.
Yeah, that's interesting. I'm a twin.
Oh, you are?
Yeah,
Oh my God, identical?
Not identical.
Okay.
Fraternal brother.
So that means your mom ovulated 2 eggs.
Yeah.
That's very interesting. Mm-hmm. Yeah, so that can happen on its own, by the way. This is an interesting tidbit. As we enter our 40s and as our egg count typically gets lower, your brain detects that and starts sending stronger signals each month. And sometimes that leads to this phenomenon where women, as they age, are more likely to ovulate more than 1 egg. How old was your mom when she had you guys?
I feel like she was 30.
Okay, so it doesn't apply there. I mean, it can happen for other reasons too. But yeah, so the risk of twins with medicated IUI is approximately 3 to 8%. And then the other thing is like, this is all just happening inside your body. So there's no, unlike with IVF, where there's ways to test the embryos, you're not able to do that. You're just hoping for the best. And we know that 1 in 4 pregnancies can end in miscarriage, especially in the first trimester, because all of us have the ability to ovulate an unhealthy egg, an error, a typo, right? And this means it turns into an embryo that has missing or extra DNA. That's the #1 cause of first trimester miscarriages, and it can happen to anyone. And that's why I always say it's not your fault. Mm-hmm. It's most likely something that you had no control over and something that you couldn't have done nothing to avoid, right? Sometimes you just ovulate the wrong egg, and that's what it comes down to, and that becomes more prevalent as we get older. But even in your 20s, that can happen. And that can happen with a medicated IUI. There's nothing we can do about it. It's just like what naturally can happen, right? And the other thing when you compare it to IVF is there's no opportunity to freeze for the future. So it's just about getting you to baby number 1 or the next baby, and you're going to be pregnant hopefully for 9 months, and then you're maybe breastfeeding or just kind of like recovering. And so you have to think about the big picture. So when someone comes to me and they're like, I'm 38 and I want to have 2 children, I'm thinking about the biological clock. And I don't think it's unreasonable or overly aggressive to say, you know, it may make sense to go straight to IVF, because IVF is a different ballgame. This is more complicated. It's more expensive than IUI. If you have no insurance coverage and you're paying out of pocket, it's more intense. There's more things that you need to do. It's a 2-step process. You're taking shots for 8 to 10 days to try to, basically you're injecting the same hormone signal your brain sends to your ovary to get it to ovulate at a higher level. You're trying to get whatever eggs are available. Every month a certain wave of eggs get recruited, and whether you use them or not, you're going to lose them. Like you either ovulate one and then the rest go away, or you can do a process like egg freezing or IVF where we're stimulating the ovaries and we're saying, let's capture and salvage all of those eggs before your body would waste them. Let's take advantage of this wasteful system. And having more is always better because it means that I have more chances to turn those eggs into embryos. So that's the only instance where your egg count really matters. Is if you're doing egg freezing or you're doing the first part of IVF, the egg retrieval, it's going to dictate how efficient that process will be and how well you might respond. But otherwise, when you're ovulating, it's not a numbers game, right? So the first part is the stimulation, having an egg retrieval, which is done under sedation. You're watched by an anesthesiologist. It's a very minor procedure. It takes 10 minutes, but it's a day you take off of work. And all the while in the lead up to the egg retrieval, you are coming in for lots of monitoring visits. So there's a lot more poking and prodding. You're getting ultrasounds, you're getting blood work, usually like every other day. So 5 or 6 early morning visits, and then you're getting the procedure. And then we're waiting to see how many of those eggs were fertilized, how many turned into embryos, which takes about a week. By that point, you're getting your period. And then if we have embryos to work with, and by the way, we can genetically test them without harming them. They have 100 to 200 cells. They separate out into cells that become the baby and cells that become the placenta that kind of line the periphery of the embryo. And now in almost like 99% of the cycles we remove some of those outer cells that one day become the placenta and send that off for genetic testing. So many misconceptions about that. The genetic testing, its main role is to identify which embryos have those typos or errors that I was talking about and which ones don't. Which ones have 46 chromosomes, which is what they're supposed to have. And so the idea is to be able to select the healthy embryo one at a time and know that if it's healthy and it looks great and it's tested, it could have up to a 60 to 70% chance of a live birth. So the advantage of IVF is you tend to get pregnant quicker. It's not a guarantee. And for some people, it can still be a struggle because A, it might be harder to make those healthy embryos if you have a lower egg count, or if you have a hard time because egg quality is an issue for you. You might get a lot of eggs at retrieval and a lot of them don't make it to that embryo stage, or they're not normal and you have to do another round to get that normal embryo. And some people have issues like fibroids, or they've had surgeries on their uterus where we have the embryos, but it's really hard to make that environment ideal for the embryo to actually stick and implant. So there's so many different ways that it can be challenging, but in general, it tends to get people pregnant faster than medicated IUI. It allows you to test the embryos and reduce the risk of miscarriage. This is a huge game changer for women who are trying to conceive in their 40s. A big thing that's been in the media lately is, the CDC reported their data saying more women than ever are getting pregnant in their 40s. There's been a massive increase, up to 70% in some states, in the birth rate in 40 plus women. And there have been dramatic declines in women getting pregnant under 35. And part of this is the rise in this technology and leveraging this technology and being able to say, now you can have a 40-something-year-old patient who normally would have had like a 40 to 50% chance of miscarriage if they had just ovulated on their own. That's not to say you shouldn't try on your own, right? But this is why we say don't try for longer than 3 months without seeking intervention. Now we can say, you know what? We can test all these embryos and dramatically lower your chances, and your uterus doesn't really age. So your chance of getting pregnant from an embryo that's transferred in your uterus is somewhat equivalent to that of a 20-something-year-old, right? You're kind of taking age out of the equation, at least when it comes to getting and staying pregnant when you're doing IVF and doing the genetic testing. And because it works so well for so many people, we're only putting back one embryo at a time. So unless the embryo splits, you're not having twins. There's usually like a 2% chance of that happening. And I think the biggest thing is also being able to freeze the extra embryos that you create from one round, because you might have multiple eggs that turn into multiple embryos. Not all of them will get there, but if you end up with multiple embryos from one or multiple rounds, they don't change over time once they're frozen. You can come back at any age. I've had patients freeze at 39. They had their first baby, they froze some extra embryos, and they've come back at 45 for their third baby and gotten pregnant on the first transfer. I mean, that is the reason behind the headlines.
I mean, it seems like such a miracle that IVF exists, right?
Yes.
I mean, and so I'm curious too. I love knowing that it decreases the chance of miscarriages, because that was going to be one of my questions.
Yes,
and
it can because of the genetic testing.
And then with the genetic testing, does it also limit your risk factor of rare diseases?
So that's a great question and a common misconception. A lot of people that have frozen eggs with me come back years later, now that they're married, ready to start trying, and they're like, why wouldn't I just use my eggs? Because then you can just test them, and then we're going to have less chance of having a child with a medical problem. And I'm like, not really. We're testing to just count the number of chromosomes, the amount of DNA. It's just looking for those typos or errors, right? There is something that you should know about, which is called carrier screening, where you can do blood work or even a cheek swab on both prospective parents, both members of the couple, and basically see, is there any risk of an overlap? Like, what mutations do you carry? What mutations does he carry? Could there be any common mutations? And going back to high school biology, Punnett squares, right? There are certain mutations where if you have both gene copies are mutated, then you have the actual disease. And so if you know that there's a chance of overlap, or a 1 in 4 chance of having a child with 2 copies of the mutation, for major diseases like cystic fibrosis, that is a major lung disease that can affect your ability to live past your 30s, right? There are a lot of major diseases on these panels, like 400, 500 conditions. And so it's routine now to do this preconception. All too often people don't know about it. They get pregnant and then they go to their OBGYN and then they get tested. And it usually is that you don't overlap, but I'd say 2 to 4% of the couples that I see and test will find that they do overlap for something. And what that means is they have options now. They can say, all right, well, we'll roll the dice and know that by the end of the first trimester, we can test the fetus if we want to and see, is this baby going to be affected? That's a really anxiety-provoking wait. Or you could say, you know what, I don't want to be in that situation. I want to create embryos. I want to genetically test them. And because we know what to look for, we can also test the embryos for that set of mutations. I have patients, and this is something I love doing, patients who have a strong family history of cancers. They find out that they are a carrier of the BRCA mutation, like a gene that predisposes them to a higher lifetime risk of developing certain cancers. And they've had this painful family history. They've lost loved ones, often a parent. And they're like, you know what? I don't want to have this cloud hanging over my head. I know I have a 50% chance of passing this on to a future child. If there's something I can do to stop that, I want to do that. And I have patients who come to me to freeze their eggs because they're like, I know I'm going to do IVF to want to stop the propagation of this gene one day. So why don't I start with younger, more plentiful eggs, right? I think it's a really special thing that this technology has afforded us the ability to halt and to give people peace of mind.
Absolutely. And Jeremy and I did the testing before we tried to get pregnant. And by the way, I came back with like 6 things that I carry. He carried none. So he always like jokes with me about that. He's like, there's definitely some inbred stuff happening in your, like, with your ancestors.
Oh my gosh.
But definitely get the test because you never know.
Yeah. I think knowledge is power. And listen, you don't have to, it doesn't mean, oh, you find out you're a match and you have to do IVF. No. I mean, I think it's just about, again, making decisions with information. My goal in writing my book and how I counsel my patients is I'm not trying to get them to do anything. You know, if they come in to talk to me about egg freezing, or they come in to talk to me about future family planning and they decide never to freeze their eggs, or they ultimately make a decision that they don't want to have children, I think that's great for them. What I don't want is someone to look later on in life back and say, you know what, I would have made different decisions if I had access to better information.
100%. I like that we talked about embryo freezing because it is something that's been top of mind for me. I'm, currently 8 months pregnant. We're about to have our first baby, but I've definitely been thinking I want to take a significant amount of time, maybe 2 years, 3 years, 4 years before trying to get pregnant with my second. I live in New York City. I want to be focused on my career for the next 3 or 4 years.
Yep.
Having a baby does, not derail your career, but it definitely sets certain things aside for a little bit of time as a woman. And I think this is something that a lot of women think about even when it comes to getting pregnant in the first place. Yes. So let's talk about secondary infertility, what people should know and what proactively we should be thinking about if, somebody's in the same situation that I'm in.
Yeah, I think secondary infertility is such a great topic. It's not talked about nearly enough. And I think that has led to a lot of social isolation for people who are going through it. Adding to the fact that they also feel guilt. It's almost like survivor's guilt. They're like, how can I complain that I'm having problems, having baby number 2 when I have baby number 1? A lot of people are struggling even to get there. But I'm here to tell you that your visual journey matters and your pain is valid. And I think people really need to fight that narrative. And I'm talking from experience because I'm someone that had secondary infertility. And because I'm so thankful, I was a fertility doctor and I was actually in training, subspecialty training. So I was already an OBGYN, but being in this environment of a fertility clinic and seeing everything that I was seeing, I decided to proactively freeze my embryos. And I didn't know if I would ever need to use them. And so it was less stressful for me because it was still distressing that I wasn't able to get pregnant at 37 when I was trying. But it was kind of like, well, I had planned for this and I ended up using what I froze. But for a long time, I didn't share that journey because it felt like it was coming from a place of privilege. Like I had the knowledge, I made a proactive decision. Therefore, my secondary infertility journey was way less stressful than it could have been. Versus if I had to start from scratch, maybe I would have needed to do, undoubtedly, I would have needed to do multiple cycles because it took me multiple cycles to be able to freeze the number of embryos I wanted because I had a lower egg count. So I think, a lot of people feel like less inclined to share and it's more isolating for them. But secondary infertility is also one of those things that is rooted deeply in denial because people find it so hard to understand. I spoke to someone today about it actually, who was 35 when she had her first and now she's 37, 38. And she's like, I just don't understand. It was so easy for me to get pregnant with baby number 1. I just feel like there's something deeper and we're not getting to the root of it. And I was like, our bodies change, right? Our bodies change in so many different ways. And we've already talked about the biological clock. If in our mid 30s, there's a 1 in 3 chance that an embryo that randomly forms from an ovulated egg could have those typos or errors, that rises to about 1/2 in our 37, 38, age range. And so it takes many more ovulations to get there. So just by virtue of the biological clock, secondary infertility is a thing. But also the more ovulations we have in our life, the more opportunity for underlying gynecologic issues that can sometimes predispose to infertility that they have to thrive, right? Like the more ovulations you have, the more chances for endometriosis to flourish, for fibroids to grow over time. And sometimes there can even be things that happen during the delivery that can result in a predisposition to fertility issues. Some women can have these structures called isthmoseals form in the C-section scar. So I'm a big believer in preconception testing, getting a scan before you're ready to start trying, because you need to know how your body, especially your uterus, has changed in the process of growing a baby, delivering a baby. Sometimes that involves surgical intervention. And I think it's really important to take a second look and look at your body from a different lens. Years later, things could be different with your fertility. And I think the biggest thing that I see as a barrier to treatment for women with secondary infertility is their denial.
This is kind of a sidebar, but when you said surgery, it made me think of this because I've been seeing stuff on this and now I'm seeing it everywhere because of course I clicked on like one video and now I've seen 10 and I'm having a baby soon and now I'm like stressed. Is it true that your placenta can sometimes not come out at birth?
Yeah, it is. It's not the most common thing, so I wouldn't worry about it needlessly. But yeah, for some women, it can be like sticky, especially if they've had surgeries on their uterus. Like there's, a higher chance of that happening. But it's not. I wouldn't say it's like the most likely thing. I don't want anyone to feel anxious, but these are the types of things I ask about. So people come back to have baby number 2, baby number 3. Maybe they were able to get pregnant with IUI, or maybe they did IVF and they're coming back to use more frozen embryos to have more children. I always do such a thorough history of how did the pregnancy go? Were there any complications? I think that pregnancy is almost like a stress test for your body. For women that develop gestational diabetes in pregnancy or they develop high blood pressure, that can be a sign that there's something that they're predisposed to from a cardiovascular standpoint or an insulin resistant standpoint. And there are reasons for me to do further testing even after they're done with their postpartum phase, right? Because those things could impact their future fertility, especially insulin resistance.
Okay, I have a specific one because I found out throughout this pregnancy that I have a low platelet count.
Okay.
Have you heard of that before?
Yeah, I mean, it can be autoimmune. Do you know the cause of it or?
No, I don't know.
Sometimes it's more just related to the changes in your blood volume and how your body changes in pregnancy. But sometimes it's an autoimmune condition. And sometimes it just develops in pregnancy. So it's something that they'll monitor and recheck your levels. But
it's scary too because it's like if your levels drop below a certain number, you can't have an epidural.
Yes. And so this is something that's kind of monitored and watched. And sometimes steroids can play a role if they think that it's autoimmune, and that can actually help mitigate things. But there's so many different things that can happen to our bodies in pregnancy. It's wild, And I spent years delivering babies and taking care of pregnant women beyond the first trimester. And now my focus is more preconception and first trimester. But everything's all related. Like never ever omit something when you're talking to your doctor and giving your medical history, because I think that there's a lot of connections that people don't make where I'm like, oh, you never mentioned that. Like, this is a major factor that I'm going to dig into deeper. And they're like, oh, okay. It's really like putting puzzle pieces together. But I really do think how our bodies behave in pregnancy can relate to our general health. And our general health can greatly relate to our fertility. It's all related.
Right. So I know we talked about how the example of freezing embryos, if you want to be somebody that, doesn't have a baby right away post having your first, right? That's kind of the situation that I'm in. But I know a lot of my friends are in the mindset of, I want to bang out all of my kids right in a row. So I'm 28, so I'm going to speak from the perspective of my friends. We're 28, 29, 30.
Yeah.
If we have our first baby at 29 or 30, how long do you recommend waiting in between the first baby and the second?
So it's usually recommended to wait like a year and a half. Anything shorter than that is considered a shortened interpregnancy interval. And there have been some studies, and this is controversial and not well established, that have associated that with a higher risk of growth issues in subsequent pregnancies if you don't wait long enough to allow your uterus and your body to really heal, and even like a heightened risk of things like preterm delivery. As a fertility doctor, I don't always tell people, hey, you just had your baby, a year ago. You need to wait an additional 6 months and then we'll do an embryo transfer, because a lot of my patients have started at an older age. And I'm also trying to weigh the obstetrical risks of another year or two. It's like, I think that there has to be a balance that you strike, and you have to look at all of the different competing interests. I would say no one should try, shorter than 6 months to 1 year. I usually recommend that my patients wait at least a year, especially if you had a C-section, right? You need to give your uterine scar time to heal and regain its strength before stretching your uterus out again and then going through labor.
Right. I didn't even think about that, but yeah, they cut into it. So
yeah. So I think it's important. And also, it takes, everyone's different. For me personally, I had 2 kids. I had 2 C-sections. I had the first C-section because my daughter was breech and she just would not budge. And they were like, do you want us to try to turn her? And I'm like, she's been breech since I was 24 weeks. I don't think she's like going to move anytime soon. So let's just do the C-section. And then I contemplated whether to try for a vaginal delivery. It was 2020 when I had my second. So I was like, I'm going to try to minimize my time in the hospital and just like schedule the second C-section, because they give you an option. Do you want to do a repeat C-section? Or I had 2 C-sections. For me, I think like going back to work very quickly after influenced how I felt and how quickly I recovered. I see a lot of articles online that like your body doesn't go back to normal for X number of years. It's like, no, for some people it's going to be faster, and for other people it's going to take longer. Just like anything in life, we're all individuals. For me, it was interesting both times. It took me exactly 18 months to feel like all of a sudden I had this moment of clarity where I was like, I feel like myself again. I feel like my body's mine, And I felt better at like 3-month intervals. Like the first 3 months were the hardest. And then at 6 months, I was like, okay, I feel better. And then at 12 months, I was like, I'm not quite myself, but I feel better. And it was really 18 months for me. But I think everyone has like their set point when they get back to feeling like themselves again. And I think that should be factored into decision making too, when you're thinking about when to come back and when to try for another child.
Like you would recommend somebody go into pregnancy having felt like their self again. Yeah.
I think that's ideal. A big one is like people wanting to try to get to their pre-pregnancy weight. I don't think we should put so much pressure on ourselves, but certainly, if you feel like, I think one of the advantages of giving yourself enough time is you're optimizing your ability to do that versus, not being in a great place, which may predispose you to things like insulin resistance, and it may compound your risk going into the next pregnancy a little bit more overweight than you normally would be, of things like gestational diabetes, right? So I think there's something to be said about, balancing all the priorities. And I think a lot of women have this sense of urgency around their fertility, which rightly so, but then also like preconceived notions about how close they want their children to be in age and things like that. And you can't control everything. I think we have to let go of some of that because, you have your plan, and then it's like your biology may have a different plan.
It's so true. And I think about that all the time. I'm always like, I have a twin, and then I have a brother that's 18 months older.
Yes.
And I loved growing up so close in age because we had the same friends, and
Nice.
It was so fun. And our, our parents' friends overlapped and all of that. And I feel like a lot of my friends also had siblings close in age. So I always kind of saw myself doing that.
Yeah.
And then it is so true. You really have to do release control on certain things, because it's like, well, maybe that's just not what works for your lifestyle.
Yeah, my kids are 3 and almost 3.5 years apart. And it didn't bother me so much, but it started to bother me as I wasn't getting pregnant. And I was like, okay, now I have a sense of urgency. Like, thank God I have these embryos, because I just felt like, wow, I envisioned them being 2 years apart. But I didn't get too hung up on it. I think something that I've learned as a fertility doctor from my profession is you kind of have to roll with it.
It's so true.
Yeah.
It's even like the
It's a
gender
healthier
of
state
kid
of
that you
mind.
have.
Yes.
Like you can't control it.
Oh my God. Yeah. And there's a lot of people wanting to control a lot of things. And again, this is a no judgment zone, but I think your life and it gets easier and your mental health is always going to be in a better place the less you try to control, especially the less irrelevant things, like the big picture things, of course, but I think priorities are really important. I have a website, theluckyegg.com, where I put like a IVF pregnancy due date calculator. But then I went one step further because I'm like, I'm inside the brain of all my patients. And it spits out all of the dates of the major things, the major milestones. First genetic test that you can do, CVS or amniocentesis, the first growth scan. Because for me as an OBGYN with all that knowledge, I was always like, okay, that was great. Okay, now you got to get to 24 weeks. And now I got to get to 34 weeks. There was always a milestone that I would get past and breathe a little bit easier and then focus on the next baby step.
What is the 34-week milestone?
It's kind of like sometimes where they do like a growth scan, like, I had gestational diabetes, so I had a growth scan at that point. It's also like where lung maturity. So for me, I was like, okay, now I know like if God forbid I went into labor a little bit on the earlier end, like the lungs are quote unquote mature. Before 34 weeks, they give you steroids if they think that you're going to go into labor early because that can try to hasten or speed up that lung maturity process. I think I'm extra sensitive about that milestone because my brother had major lung issues because he was born so early. But as an OBGYN, that's how your brain thinks. You're just like, okay, I got to get to this milestone because then I can put all of these other worries aside and now I can worry about the next milestone. But I don't think it's unhealthy to think that way. I think it goes back to what you said about compartmentalization.
It helps.
Yeah, for sure.
Okay, let's talk about miscarriages because as we've said, it's 1 in 4 pregnancies end up with a miscarriage. So, I've had friends recently go through miscarriages, so they specifically want me to ask you these questions.
Yeah, of course.
When it comes to having a miscarriage, how long do you recommend waiting to try to get pregnant again?
So there's no specific amount of time. The markers I look for, basically, if a patient of mine has a miscarriage, I will bring them in for blood work, a few weeks later to just see where their HCG, their pregnancy hormone level, is at. And HCG has a very long half-life, meaning it takes a long time to clear out of your system. So depending on how high that level looks, I might bring them back in another 2 weeks. And then, just periodically check in versus giving them some kind of like fake deadline of, okay, when you get your next period. Because what people don't realize is that when you're pregnant, your body is not sending that signal to your ovary to ovulate anymore. But once you're in this state of recovery after a miscarriage, your brain starts to send signals to the ovary. And so in the background, you could be ovulating as your HCG level is still kind of trending in this downward direction. So you could get pregnant. I think it's clinically a little confusing if you have an elevated level and then you ovulate and you get pregnant. So we normally recommend let's get to a resolution negative pregnancy test at home. I often will do blood work to just kind of check in. And I try to be proactive about it because every once in a while, the blood work starts kind of plateauing and you're like, oh, maybe we need to do imaging. I like to stay on top of things. And so this is not the most common thing to happen, but sometimes tissue can be retained where you're like, oh, that's why the HCG level's not dropping, right? Or that's why you're having this irregular spotting and that needs to be treated so that we can get you on the path to resolution so you can get back on the road of trying again. And so once someone has a negative HCG level, a negative home test, if they're testing and just tracking on their own and they're not under the care of a fertility doctor who's being super vigilant, at that point, it's like, okay, you'll get a period. You might be in the middle of ovulating. And so your period, even after your level's negative, like you'll get a period 2 weeks later. Just start trying. You don't have to have a certain number of periods. There isn't like a 3-month waiting period. There's all these recommendations I see online that are just made up. I don't think there's a reason to delay. I think also your mental health. When do you feel mentally ready to get back on the path of trying? I think if you check all 3 of those things, like you've gotten it's not even that you have to get your period, but I think, that's when you can start cycle tracking again and establish, okay, like this is my baseline. And you have a negative HCG test, the pregnancy hormone's out of your system, and you feel mentally ready.
And what do you say to patients that recently had a miscarriage? And obviously it's something that's extremely upsetting. What do you say to kind of re-encourage them, let them know that it's okay, this is a normal thing to go through?
Well, I often think to myself that there's some evolutionary benefit to the fact that HCG lingers for so long, and it's like takes time to get out of your system. It's very frustrating, don't get me wrong, but oftentimes the state that a patient's mental health is in when they first discover that they have a miscarriage, and we're going through the miscarriage management, there's different ways to manage it. You can kind of wait and watch, not usually my style. So usually I use medications, or I'll do a DNC, a procedure, and there's pros and cons to either. But we manage it, and it's a really sad time, and they might just feel like so shut down mentally. It's not even really possible to have like a proper conversation sometimes, because I know they're not retaining a lot of the information. They're just in the state of trauma. I find that by the time, their HCG level is negative, it's like that built-in break, I think, does wonders for people. I mean, don't get me wrong, it's still difficult, it's still hard, but I feel like people are like, they have more mental strength and fortitude at that point where they've like picked themselves up off the floor, right? Obviously, we're supporting them as much as we can, but I think time does heal all wounds. And while there might be some trauma that's still there, I think you need to give yourself a necessary waiting period to feel ready again. I think something to over anticipate is this like PTSD like phenomenon where you may walk, if you're going to fertility clinics or even your OBGYN, when you walk back in that first time, you might start to feel like, okay, my pulse is racing, or I'm feeling upset. I think it's a really good idea to not do that alone. I think like those are the things that people don't realize until they're in it, that I often will warn my patients. I'm like, when you come back here, you're probably going to feel a certain way, right? And it's like desensitization therapy, enough visits back where you can associate this place with not that negative event that happened in your life. That's going to help work through this, right? But I think that pregnancy loss oftentimes can manifest as a form of PTSD for a lot of women.
Oh, yeah. And I completely agree. I am the women that are able to go to pregnancy appointments on their own have a different type of thick skin, because I cannot go without a friend or my husband.
Yeah, it's good because you don't know what you may learn, and it's just like an anxiety provoking time. And oftentimes, when you're the subject, right? Mm-hmm. And everyone's doing the tests and you're being poked and prodded, it's not always easy to remember all your questions. I think it's really a good thing in terms of self-advocacy to have someone there to help keep you on track.
Yeah. All right. So you mentioned the amniocentesis.
Yes.
I want to talk a little bit about this from your perspective, because I got offered the amniocentesis after my 20-week anatomy scan.
Yeah.
Basically, the situation that we have with our daughter is that one of her kidneys is polycystic.
Okay.
They think that's like what it's potentially going to be, but the other one's functioning normally. Right. A lot of people have one kidney or one functioning kidney. Yeah. I actually have a cousin that has a pelvic kidney. Yep. So it's probably a genetic thing in my family. I'm like, of course I got it out of all of the siblings. And but regardless, I got offered the amniocentesis test, and we're, obviously Jeremy and I aren't in the healthcare world. We were very overwhelmed by the stats of it, because 1 in 300 people can have a miscarriage from doing it. Right. So what are your thoughts around the amniocentesis? Would you recommend it? What do you tell patients that get offered it?
I mean, I don't think it's something that everyone has to do across the board. I guess just like backing up, the whole purpose of tests like chorionic villus sampling, CVS, which is done at the end of the first trimester, or an amniocentesis, which is basically drawing up amniotic fluid. And it is kind of scary when you think about how it's done. It's like with a long needle, and it goes through the abdomen under ultrasound guidance, and then you're piercing the amniotic sac and drawing up some fluid, because the fetus is surrounded by fluid, the amniotic fluid in the sac, and it's constantly shedding its cells into that fluid. And so you're able to actually sequence the DNA and get a really comprehensive look at the genetics of a fetus. And so, the first step doesn't have to be one of those invasive tests. The CVS is where they're actually going in with a needle and taking a small part of the placenta that's just developing, in the first trimester. So they're both invasive. They both come with certain risks, but they're done because you're able to, at that stage of pregnancy, get enough tissue to have enough DNA to go deeper and ask more detailed questions. And so for anyone who may have something that comes up as a red flag, which initially, the standard test is really a non-invasive prenatal test, which is a blood test. And the earliest that can be done is like at the tail end of the first trimester. So most people as a standard will get that done because it's just a blood test. And then if there's a marker that's elevated that's like, hey, you look like you could be at an increased risk of Down syndrome where there's 3 copies of chromosome 21, or there's something else going on that's maybe a red flag or inconclusive, at that point you can choose, do you want to do a CVS, get earlier information, or do you want to wait and do the amniocentesis and do this a bit later? There's pros and cons to either. But I think, if there's something that comes up as a question or a red flag, it might be worth doing it. But again, you're going to be counseled that there can be certain risks because it's an invasive procedure. And so I think the decision is deeply personal. I recommend amniocentesis to my patients when they do genetic testing for a specific gene mutation, because the genetic testing of embryos works really well, but there's always, with any test, a rate of error. And if you went out of your way to test these embryos and you were desperately trying to avoid something, I always think that it's a good idea to do confirmatory testing. It's standard of care and recommended. There is this misconception that women that did IVF and genetically tested their embryos don't need to do any prenatal genetic testing, and that's actually terrible advice, because it's so little DNA that you're able to collect from just a few cells from an embryo that you could be missing a lot of information. I always say pretend as if you didn't do IVF, pretend as if you didn't do the genetic testing, and do the level of genetic screening or diagnostic testing that you would have done otherwise. But most people take a stepwise approach, and then obviously it can come up if things come up on the anatomy scan that suggest, hey, there could be something genetic going on. But I think it's really a risk-benefit calculus and what you're comfortable with. It's not something that everyone needs to do. As an OBGYN, I'm the worst patient. And I knew too much. And there are things that you can pick up on CVS and amniocentesis that you can't get from just the non-invasive prenatal test, blood test. So I wanted to know everything. And they were like, do you even want to know the variants of undetermined significance? And I was like, yes, give it to me straight. Even though I knew that would drive me nuts, because I'd be like, what does this gene variant mean? I'd be looking it up like till 2 a.m. I was very lucky it came back normal. So it's one of those like, you could be your own worst enemy. But as an OBGYN, and even as a fertility doctor, which is why I was so, cautious and froze embryos, which I'm glad I did, but it could have worked out that I didn't need them, right? And so I think as a doctor, I tend to be like overly vigilant for myself and my own healthcare journey, overly cautious. And sometimes I'm glad that I'm like that. And sometimes I'm like, okay, you need to calm down and not drive yourself nuts.
But it is so good that because I would look at the results of an amniocentesis, and if I was to see anything that was like cause for concern, I would probably send myself into a spiral without having needed to.
I agree. And I think that's like one of the big criticisms. This is totally off topic, but like those full body MRIs, people are like, well, why would you do that? It causes like undue, anxiety. But I'm like, I can kind of interpret if a cyst is benign or if it's not relevant or doesn't need follow-up. So I don't know, maybe I'm being cocky, but I tend to like more information, not when it comes to wearables, right, when it comes to diagnostics.
Right, it makes sense. I mean, you are a doctor. Okay. All right, so we're going to do some bonus questions. First one is, what myths do you see on social media that you find to be especially harmful when it comes to getting pregnant?
Yeah, I think the biggest myth is we have a formula, a program, a supplement, a tincture, a tea, something that's going to fix all your problems. I have seen the craziest things. I've seen people promote supplements to unblock tubes. I'm like, how does that work? Like that doesn't even make sense. I saw something today, and a lot of this is like my followers on Instagram. Every day I get flooded with at least 50 different DMs from different people, and it's usually like, is this legit? And then sending me a post. And I've seen a major uptick. I'm like, what is going on with the misinformation cycle right now? But I saw one today of a woman that was wearing this like red light device, but on her abdomen. And it's like, this will help your egg quality. And I'm like, scientifically, that just does not make sense, right? It might help the skin of your abdomen look like more youthful and tighter, but like it's not going to get to your ovaries and do anything to fix your egg health. And so there's a lot of magical thinking and marketing and targeted ads, and they're targeting us, specifically women and those who are trying to conceive or already pregnant or postpartum, because it's so easy to manipulate our fear and our desperation to want to control things and do right by our future child. And it's like so easy to manipulate that for their financial gain. And it's really, really infuriating. And it's the thing that really motivates me to be chronically online and making videos till all hours of the night outside of my day job, because I just feel like if I'm not going to use my voice and expertise to quiet that type of noise and nonsense, who will? It will be just running rampant, and it already is. And I'm seeing more and more experts get online, which makes me happy, but it's just like a never-ending problem. And I think what we can really do is educate people on how to examine these things critically and look at things with a certain lens of skepticism. We need more skepticism and cynicism in the world of social media right now.
GLP-1s. Is it true that being on a GLP-1 can increase your chance of getting pregnant?
Yes, they call this Ozempic babies. It can help, especially if women have underlying insulin resistance. Insulin resistance is this throwaway term that you hear like a lot of wellness podcasters talking about, but it is a real problem, and I diagnose it in a large proportion of patients with infertility. It's not always just women with PCOS. It can be, associated with excess body weight. Insulin is a hormone that helps you store blood sugars effectively, and having excess weight, especially around the midsection, having a strong family history of type 2 diabetes, having PCOS, there's all these like clues and clinical markers that kind of like smell of insulin resistance, and you can do blood work to rule it in or out. You can look at body composition. There's those scans that you can do. And basically it is a condition that is like a vicious cycle where your body's not listening to insulin. It's not storing blood sugars effectively. And then it makes you churn out more insulin, because that's what hormones do. If they're not getting listened to, they yell, they create a higher signal. And that can, as I said earlier, affect how our ovaries behave. It can make your ovaries overproduce testosterone. It can create an unhealthy environment around the ovaries or around the eggs within the ovary, so that they're more error prone. So even if you're young and you're like, wait, why am I having, poor results with egg retrievals? A lot of my eggs aren't turning into healthy embryos, or I'm having miscarriages and they tested the miscarriage. I did a DNC and it was genetically normal. How do you explain that? It's like, well, maybe we need to correct the insulin resistance, because that could be an underlying risk factor for not just egg quality issues, but also things like miscarriage or not having embryos implant, whether you're trying on your own or through treatment. So this is a very real thing. It's very prevalent because we live sedentary lives. A lot of us are sitting at a desk 12 hours a day, not prioritizing movement in the way we should, not building muscle the way we should, because muscle building is like the antidote. It actually makes you much more sensitive to insulin and helps correct a lot of that metabolic dysfunction. So GLP-1s are very, very good at treating insulin resistance. And therefore, if you're correcting that underlying problem, oftentimes women who haven't been ovulating regularly can start ovulating, especially if they're overweight and they've lost some of the weight. That can be really helpful. Correct all of those underlying disturbances that I mentioned, but GLP-1s are not safe in pregnancies. So it's really tricky, because there are women that are like, oh, I don't need to be on contraception, I never ovulate. That's not a great plan, right? Especially if you're doing something that's changing your metabolism, you might start ovulating. So you want to be aware of that. And there are potential risks in pregnancy that have been documented: growth restriction, lower birth weight, even certain birth defects. And so we really want to be careful to have a washout period of ideally 2 months before getting pregnant.
And maybe make sure you're going to a reputable source to get it from.
Yes. Oh my gosh. I mean, you really have no reason to go to like compounding pharmacies. Like now there isn't a drug shortage, and you can get this through reputable sources and know that you're getting the same type of formulation every time you're taking it.
And also your insurance might cover it. So I feel like that's also good bang for buck.
Yes. And now there's oral forms, so it doesn't have to be injectable. I mean, that can reduce the rate of side effects potentially.
So Dr. Lucky, your book is now for sale. Everybody can pick it up. It's called The Lucky Egg. What is one thing you want everybody that reads this book to take away from it?
I want them to feel like it's not so complex and scary, the issue of their fertility and what they need to know. I want them to walk away feeling calm and confident and just sure of themselves and what their next step should be. I think it's a really simple, easy to access roadmap. I always say it's like, the idea of just going through life and not getting this formalized education feels very much like driving on a freeway and not having looked at GPS or plugged in my destination and just relying on, going so fast and having to navigate like, here are the signs. Let me just swerve, lanes because I actually need to get off at this exit. that's how you make bad decisions. And so I just want people to be really thoughtful about what they want out of life and understand a better strategy that's logical, that's not rooted in fear mongering or misinformation or trying to sell people things. That's just giving them all the facts so that they can make an informed decision for themselves.
And where can everybody follow you to stay connected with everything you've got going on?
I'm most active on Instagram at lucky.sekhon, Sekhon. I'm on TikTok at Dr. Lucky Egg because lucky.sekhon was taken apparently. I have a website, theluckyegg.com. I have a lot of cool calculators like an egg freezing calculator, an AMH tool, lots of interactive tools, even that pregnancy due date calculator that gives you the milestone dates for your pregnancy. And then my book's everywhere. And there's an audio book, there's an ebook, and I'm based in New York City. I work at a practice called RMA of New York, and I'm still a full-time doctor that sees patients.
Thank you so much for being on Post Run High today.
Thank you for having me.